Today, I have the very great pleasure of introducing Amitabh Chandra, who is an economist, the McCants Family Professor of Business Administration at Harvard Business School, the Ethel Weiner Professor of Public Policy, and Director of Health Policy Research at the Harvard Kennedy School of Government, visiting scholar at the American Enterprise Institute, and an elected member of the National Academy of Medicine. Dr. Chandra is a prolific researcher with research focused on innovation in healthcare, finance in healthcare, productivity and cost growth in healthcare, medical malpractice, and racial disparities in healthcare. Dr. Chandra's research has been supported by the National Institute of Aging, the National Institute of Child Health and Development, the Robert Wood Johnson Foundation, and has been published in the American Economic Review, the Journal of Political Economy, the New England Journal of Medicine, and the Journal of American Medical Association and Health Affairs. We're very honored to have you. Thank you so much for joining us.
Thank you. My pleasure. So, Jennifer, should we ways? I have a couple of slides.
Okay, so I think Kirsten or Serena can make you a presenter and have you share your screen.
Excellent.
You're a presenter, so you can just share your screen.
All right, let's get started. Ooh, I don't think that works. Can you all see my screen? Does it work? Can you see some slides or no? That is unfortunate.
We saw them a moment ago.
Yeah. You know what sometimes works is I'll just not put them in presenter. I know for sure. So I won't put them in presenter mode. I'll just walk you through these slides. There we go. So I think that works, right? You see the slides are not in presenter mode, but they should all be legible. I want to talk about a huge topic that so many of us have been working on, which is racial disparities in healthcare. And just to set it up, I think we have this view in social science that health is caused by a variety of different things. There's healthcare, of course, there's neighborhoods, which might be responsible for social determinants of health. There's income, there's the behaviors themselves, there's genes, there's stress. So there's many, many things that affect health. I don't think that this is going to be surprising to anyone to say that what matters at the end of the day is a lot of different inputs. I think, however, that the world isn't so tightly organized, so cleanly organized. I think the real world looks like this, right? So it's just very, very hard to say, I have figured out the effect of income on health, or I have figured out the effect of genetics on health, because the reality is that everything affects everything. So it's a really, really hard question. And I want to emphasize the difficulty of this question, because at the end of the day, if the world looks as messy as this, right? If everything really is connected to everything else, as I do believe it is, policy is going to be incredibly hard. Because if I change income, sure, it gets me better healthcare, but it also changes my neighborhood. And if it changes my neighborhood, does that automatically mean that I get better healthcare, or does it mean that my healthcare gets disrupted for a couple of years while I figure things out? So what I'm going to be doing, just in the spirit of humility, is talking about a very specific, very narrow channel today, the effect of healthcare on health. And I want to just acknowledge that, because I don't think, and I've never thought, that this is the biggest or the most important channel. It's the channel that I'm most expert to speak of. But at the end of the day, if we want to reduce racial disparities in health, we are going to have to think about the United States' very complicated history, its very embarrassing record on racism. We're going to have to think about those things, right? And we're going to have to talk about those things. And maybe we have to talk about them when we're talking about the relationship of healthcare to health, but we're certainly talking about them a lot less when I draw the arrow the way that I have than if I had put it up on than the way I had it on the previous slide. So what I want to talk about on healthcare and health is also a very specific topic. I want to talk about this idea that when in this relationship, in this arrow that links healthcare to health, there are a variety of things going on there, right? There could be, and there is, provider prejudice, provider bias against minorities, against African-American patients in particular. There could also be trust. The patients themselves might be distrusting of the provider because of the country's long history with racism. There could also be what I'm going to talk about, differences in allocation. So African-American patients could be going to different providers than their neighbors might be. And if those providers are less well resourced, then we're going to start to see differences in health. So that's a particular angle that I'm going to talk about. That might be related with trust. It might be related to opportunity. So we'll try to have that discussion today, but it's a different channel than saying providers are biased, right? It's a different channel. It could be co-occur, but it's a different channel. But to highlight this, I want to take you to a graph that's quite old now that I put together about a decade ago, but it hasn't changed. What I'm graphing for you in crimson are areas of the United States where the population has 3 times as many African Americans relative to the US average to 6 times as many African Americans relative to the US average. So areas in crimson, so just think about it this way, this is Medicare claims data. So in Medicare, about 12% of the population is African American. So if you're seeing an area that's crimson, that's a part of the United States where somewhere between 35, 36% of the population is African American, all the way up to like 60 and beyond, right? So why did I put this up there? I put this up there because if we're going to get serious about improving healthcare for minority populations, we're going to have to think about healthcare in those areas in crimson a lot, because that is where the elderly African-American population is. And it's not the case that the younger African-American population is spread out uniformly across the United States, but they are spread out more uniformly than the elderly. So just keep that in mind. So even if we take nothing away from my talk, I do just want to highlight that the states that we ought to be thinking about, Mississippi, Alabama, Georgia, the Carolinas, those states tend not to be the states that get written up when we're talking about, opportunities to reduce racial disparities in America. We're often talking about how some great hospital in Boston is doing things to reduce disparities. And while I applaud that hospital and I live in Boston, let's just be clear that that is not going to do the job that we need to get done for the United States. That job requires us to focus on a very different set of hospitals and providers. And you can see this even more starkly in my next slide. I got 2 lines for you. Look at the graph on the left first. I've got 5,000 hospitals, all of which treated a heart attack in Medicare. And I'm graphing for you on the y-axis the cumulative percentage of all heart attack discharges that those hospitals accounted for. Now look at the striking difference between the number of hospitals that are responsible for treating African-American patients versus white patients. The 1,000 hospitals that treated the most African-American patients account for something like 85% of all African-American heart attacks. That's what you should be taking away from that. And the 10 hospitals with the largest number of African-American patients, so these would be hospitals ranked 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, all the way on the x-axis, account for something like 20% of all African-American heart attacks. So if you really want to help African-Americans reduce racial disparities in Medicare, we're talking about giving tremendous resources to 10 hospitals. It's not easy to do, but that is a very different enterprise than saying we have to reduce racial disparities in Provo, Utah, and Salt Lake, Utah, and in Los Angeles, right? Like we got to think about those 10 hospitals. On the right, it's the same graph, but it's at the doctor level. So if you look at all the doctors who treat heart attack patients, basically if I go for the 50,000 physicians who treat the largest number of African-American patients, I would have changed the lives, I would have changed the healthcare for about 80% of African-American patients, right? So I want us to remember this, because what it's saying is targeting is going to be incredibly important. Right? Well, let's talk about how we do the targeting. It's going to take money. We should not be shy about that. But America is so segregated today. It's still so segregated. I guess that's what these graphs are saying. It's still so segregated today that if we want to reduce racial disparities in healthcare, we should think about those providers who actually help African American patients, and think about resourcing them better, which is a different enterprise than helping all providers. Now, what I want to spend some time with you today on is a paper with Pragya Kakani and Adam Sakarni. Adam is a professor at Columbia. Pragya is an amazing graduate student at Harvard that we just put together. And here's what we're going to talk about. We're going to talk about hospital allocation and racial disparities in healthcare. So we're going to focus on heart attacks. And we're going to ask, what are the differences in quality of care received by Black and white patients when they suffer a heart attack? And in particular, we're not going to look at what everybody else has looked at, which is how does a given hospital treat an African-American patient differently than a white patient. That is going to be what I'm going to call provider bias. It's incredibly important, right? So we're not trying to minimize it in any way. We're going to talk about a different channel. We're going to talk about, is it the case that African-American patients, when they have a heart attack, go to a different hospital than a white patient who's having a heart attack? That's what I'm going to refer to as hospital allocation. They might go to a different hospital for a variety of reasons. They might go to a different hospital because their parents went to a different hospital, right? I mean, it's only relatively recently that we desegregated the hospitals, right? So as a lot of elderly African Americans, people who are 75 years old, 80 years old, so not super elderly, grew up in a world where they grew up in a world where hospitals were segregated. So the fact that we integrated the hospitals in 1965 doesn't mean that these patients automatically changed where they were going. Right? It could be also biased by ambulance drivers, or their primary care physician tells them to go to a different hospital than the one they want to. And you might also be wondering, why are we looking at heart attacks? And we're looking at heart attacks primarily because for two reasons. Well, three, I guess. The most important reason is virtually everyone who has a heart attack receives treatment for it. And that is not the case if we were looking at racial disparities in, say, the quality of care received by diabetics, where a lot of African-American diabetics might just not get diagnosed with the disease. So diagnosis is less of a problem with heart attack. The second great thing about heart attacks is quality measures, in particular risk-adjusted mortality, have been validated as a quality measure. What does that mean? That means that if we're looking at two hospitals, one has an 80% survival rate, one has an 85% survival rate, that 5 percentage point difference in survival reflects an actual 5 percentage point difference in survival that a patient would experience. It's not picking up, the patient's being healthier at the hospital with the 85% survival rate. So risk adjustment is an issue, but it's an issue we have dealt with when it comes to measuring the performance of hospitals for heart attacks. We've not figured that out for cancer. We've not figured that out for diabetes. I don't think we figured it out for congestive heart failure either. So that's the reason I'm looking at heart attack. I don't mean to say that it's the most important condition, although it's the acute manifestation of cardiovascular disease, which is the #1 killer in the United States. And I do also believe that we can learn a lot from heart attacks and apply design policy and apply it to a variety of other conditions. So with all that said, what are we going to do? Let's just tell you a little bit about the data. We're looking at Medicare claims data. You can see patient survival. You can see that these patients are very sick. These are all patients who have experienced a heart attack in Medicare. And look over on the right. I'm going to show you two distributions of hospital quality for white patients and Black patients. Notice how hospital quality for Black patients on average is the red line, and for white patients is the black line. And it's better by about 1 percentage point for white patients than Black patients. What does that mean? It means if you do all the risk adjustment, on average, African-American patients go to hospitals that have 1 percentage point lower 30-day survival. Now you might be thinking, do I care about a 1 percentage point difference? And the answer is yes, you do. If that was a drug, if you had a drug, if the world had a drug that could improve mortality after a heart attack by 1 percentage point, it would be a breakthrough. It would be a phenomenal. If you think about technologies like reperfusion, if you think about technologies like angioplasty for heart attacks, they all improve heart attack survival by about 2 percentage points. So this 1 percentage point gap that we're talking about is about half the magnitude of angioplasty. And angioplasty is considered single-handedly as being one of the greatest, therapeutic advancements against heart attacks. So what we're going to start with is this fact, which is that African-American patients in the late 1990s were on average going to hospitals that were that had a 1 percentage point higher 30-day survival rate. Fast forward 20 years to 2014, and you can see hospital quality has improved for both groups, and that gap has shrunk a lot. It still remains, but it has shrunk a lot, and we want to understand why has it shrunk a lot, right? That's what we want to spend our time talking about today. So that's the fact. And so now we can kind of start to decompose the fact. If you look at the fact in the first panel, it's saying that, look, there was this 1 percentage point difference. What explains the 1 percentage point difference? About 45% of that 1 percentage point difference is just the fact that African Americans and whites live in very different hospital markets. African Americans are, say, more likely to live in Memphis, Tennessee, than they are to live in Nashville, Tennessee. I'm not saying African Americans don't live in Nashville, Tennessee. I'm just saying they're just more likely to be in Nashville, Tennessee, in Memphis, Tennessee. African Americans are more likely to be in Atlanta, Georgia, than in Toledo, Ohio. So that difference of living in different hospital markets is about 45% of the gap in the upper panel. The remaining 50% of the gap is two things. It's 25% of that 50%, so half of that remaining 50%, is the fact that even conditional on living in the same city like Chicago, African Americans are more likely to live on the south side of Chicago than on the north side of Chicago. But 25% of the gap is the fact that even if I look at a white patient and a black patient who live in the same zip code, so now I'm looking within zip code, African Americans within zip code tend to go to hospitals that have lower survival than black patients. That was true back in 1995 to 2000. So think about what I just said. I said, in the late 1990s, if I compared the hospital quality in Medicare, where everybody's insured, for an African-American patient having a heart attack to a white patient having a heart attack, and these are two patients who live in the same zip code. Zip codes are incredibly small. The African-American patient is going to a hospital that has higher mortality, that has lower survival. That explains about 25% of the gap, right? Now, fast forward to 2010, 2014, what changed? Here's what changed. What changed was that those big macro differences in geography, the fact that the hospitals in Memphis may not have been as good as the hospitals in Nashville, that went away. There was incredible diffusion of new medical technologies such that those wide market level differences for disparities went away. They went away almost completely. What has not gone away at all, though, it hasn't gotten worse, but now it accounts for a much larger share of disparity, is the fact that whites and blacks who live in the same zip code still experience different outcomes because of where they go. And so it is still the case today that African Americans tend to go to hospitals that have higher mortality. And we should, as a group, try to understand why that is, but also what can we do about it. So I want to kind of get the conversation started, because I could keep talking about this forever, but I just wanted to kind of leave you with this general idea that for a lot of our history, the primary reason that minority serving hospitals were not doing as well was because they were sort of behind the technological frontier in some ways. New medical innovations had not diffused to them. That was true as late as the late 1990s. But just in the past 20 years, that story has gone away. Right? That's gone away. That is no longer the case. It's not about technological frontiers and access to technology. Minority serving hospitals have had big improvements in quality. Big. Not enough to equate the quality gaps between the two groups. And so what is a remaining puzzle for us is why is it that African-American patients who could go to a better hospital than the one they're going to still go to a hospital that has slightly higher mortality? And I think that's probably a very rich story about trust and bias that we should start to unpack. We should also have a discussion on what public policy can do. And one of my views is that this is a disparity we're seeing in Medicare fee-for-service, where people are free to go essentially to whichever hospital they want to go to. And that's a problem. And that's good in some ways because people are free to go. On the other hand, if patients don't have the information about where to go, or if they perceive a good hospital as still having, a poor experience for them, they're not going to go. And so we have to think about ideas like maybe it's Medicare Advantage, maybe Medicare Advantage, which is, private health insurance for people over the age of 65, could be deployed to create narrow networks where you discourage patients from going to hospitals that have higher mortality. That's just one idea. I'm not saying that's the only idea out there, but it is unfortunate to see patients drive right past a better hospital and keep going to the hospital that they've been going to for 20 or 30 years. So this is hopefully going to be a conversation about behavior change and about information. So I'm going to just wrap up with a couple of slides. There are many sources for disparities in healthcare, right? There's hospital allocation, which is what I've talked about. There's trust, which runs around with hospital allocation. But even if we lived in this world where there are patients can go to high quality hospitals as much as they want, if they don't see a high quality hospital as being high quality for them, they might still keep going to a hospital that they've been going to for 30 years. What I've not talked about are other sources of disparities in healthcare. There's science bias for sure. The clinical studies are often underpowered to detect effects for African-American patients. This is going to be very true for diseases that have an epigenetic basis for them, like Alzheimer's. So we should often think about, how can we reduce disparities in care by enriching clinical trials? I think we should be talking about medical innovation, what it can do and what it can't do as a driver of racial disparities in healthcare. We should talk about what markets can and cannot do. It's my view that Medicare Advantage could, for example, help reduce some of these disparities, but we don't have direct evidence of that, and that's something that we should test. I think what pains me a lot as a policy person is that rather than having the conversations that the first 4 bullet points encourage us to have, we often have conversations that are sort of just at the level of labels. We just say, well, we got to do something about population health. We got to do something about social determinants of health. I think those are just labels. I think ultimately we got to figure out which population health program do we want to implement? Is it housing? Is it Meals on Wheels? Is it transportation? And the answer for the Henry Ford Hospital in Detroit might be very different than the answer for, Cook County General. So I think talking at the level of the labels, even though the labels are probably correct, is too blunt for actual public policy. I think we need to be much more precise in what we mean when we are talking about these labels. I think we're going to have to separate the role of these distal factors from the proximate factors. A proximate factor would be, the patient's ambulance driver took him or her to the wrong hospital. A distal factor would be something like a lifetime of growing up in a neighborhood where you were not given information about what the good hospitals were, caused you at the time of needing care to select a poor hospital. We're not going to be able to change that neighborhood right away. That doesn't mean we shouldn't try. It's just going to be hard to do for heart attack patients today. I think we just need a lot more evidence about what works and what doesn't. And I don't think the labels always give us that evidence. So I didn't show you all my slides. I just wanted to get the conversation started. So I'm going to stop right there.
That's amazing, Dr. Chandra. Thank you so much for that presentation. I could ask you probably like 1,000 questions based on that alone. But one question that kind of popped in my mind as you were talking is the idea of using market forces to shift individuals from driving by the bad hospital and going to the good hospital. Can you talk, is there anything in your data that says that within a certain zip code, Black patients who go to the good hospital outperform Black patients that go to the bad hospital? Or is that bias and distrust result in outcomes that are similar, worse, better? Can you talk a little bit about within the zip code shifts?
Yeah, Benson, thank you for that question. That really is the central question. There's nothing in our study that tells us what would happen to the experience of a Black patient if we were to change their hospital. Our prediction is their survival would go up. That is our prediction. That's why we have to test this. The theory that's backed up with a lot of data. What we're able to say to you is using validated measures of quality and comparing African-American patients to white patients, zip code by zip code in the United States, right? So not just one zip code by zip code, so like 30,000 zip codes. Again and again, on average, African-Americans are being treated at hospitals with higher mortality, which suggests that you wouldn't have to totally disrupt their care by getting them to the same hospital that, say, white patients were going to. It could be, as you're pointing out, Benson, the case that survival goes up for the African-American patient, but patient experience goes down. It could be. That is a possibility that I'm open to, but it is my strong sense that we should test the hypothesis, because it could be that patients just don't know. They just don't know. How would a patient know about the quality of care at a hospital that they've never been to? I think at least giving them the option, giving them the report card, working with church groups, ambulance drivers, their PCPs, giving them that information could be transformative. And that's where I come back to this idea of markets. It doesn't have to be markets, right? It could be very grassroots level organizations that do this. Markets, of course, if you incented markets to do this, if you created, we have all these quality measures for Medicare Advantage, all these quality measures, most of them are unvalidated. Suppose we came up with a new quality measure, which was like racial disparities in outcomes for heart attack patients. My prediction is Medicare Advantage would figure out how to reduce the survival gap overnight, right? So I think that's how we should be thinking about markets. Rather than telling them how we want them to do it, we should be telling markets what we want them to do and then seeing, what they do.
That's wonderful. I think as a organization, PTech is really have a strong belief about using the market forces and payment reform in order to drive change in health inequities. I understand that you have a time limitation, Dr. Chandra, so I just want to thank you for participating today, and I really appreciate this talk. Again, I could ask you a gazillion questions, and I really appreciate your insights today.
Okay, thank you, Benson. My pleasure.
Thank you.
Thank you, Dr. Chandra. We also today have Jackie McRae, who is a director of policy research and membership at PhRMA, focusing on health equity and the value of medicines. Dr. McRae graduated with a doctorate of pharmacy from Mercer University and Masters of Science in Applied Health Economics and Outcomes Research from Thomas Jefferson University. She previously worked as a postdoc fellow in health economics and outcomes research at Janssen Scientific Affairs and Thomas Jefferson University. Thank you for being here with us. And I'm going to turn it over to Benson.
Dr. McRae, please.
Hi, everyone. Thank you, Dr. Chandra. I know he's off the call, but that was a really excellent presentation. I too have just a few slides. I'm going to pull those up. And I just want to thank everyone for being here today. All right, again, if this works. My name is Jackie McRae. I serve as a director of policy and research at PhRMA. And today I'm going to be talking about gaps in data and health disparities and what we really need to do to make meaningful impact in health equity in this area. As it was stated earlier, my background is in pharmacy and also health economics. And I'm currently studying to get my PhD in pharmacoeconomics at the University of Maryland, Baltimore, with a firm interest in health equity. So today I'll be speaking about this paper, which was conducted at PhRMA in our research, but then also really be weaving in my own experiences as a pharmacist providing care, and then also my training and background in health equity. As we start to talk about this topic today, I'm really reminded of my grandmother. So my grandmother, Black woman, she actually died of asthma at a pretty young age. So when we think about gaps in data, specifically as it relates to health disparities and race and ethnicity in particular, I think about my grandmother, right? Because she would have been one of those people who was a Medicare data point in the data as having a negative health outcome that we really probably couldn't explain. She only had asthma, took very good care of herself. And so it's a question, right, of whether or not racism was linked to this negative health outcome that she experienced. And so this gaps in data is important because we're not only looking at data, but we're looking at patients, we're looking at families when we analyze things like Medicare. So sorry, this view is a little weird. But again, today we're going to be talking about data and really why it's key to addressing racial and ethnic disparities or inequities. We know that data has played a large role in really inspiring action to really tackle racial and ethnic disparities and injustices. So 19 really classic landmark paper of that is the 1985 Heckler Report, which really started to uncover and unmask a lot of the racial and ethnic disparities that we see in our country as it relates to healthcare. We've also seen more recently that in communities that have decades of systemic inequities, such as the Bronx and Detroit, we've seen a disproportionate impact of COVID-19 related deaths, which has really garnered this mass call for health equity, right? And really has uncovered what we've always known, but it's really this data has really kind of driven these justice calls. And lastly, a topic that really hits home for me is pregnancy-related deaths. We know from research that African American, American Indian, and Alaska Native women suffer death at the result of pregnancy 2 to 3 times more likely than white women. And that's even after we sparse out for education and income. So a lot of times we may say, well, oh, those are just patients who have lower income, or maybe they're just receiving, they just have lower income or a lower education, but that's not the case, because even after we adjust for these things, we see that Black and these other women are still having higher rates of pregnancy-related deaths, right? And so we know then that the results that we're seeing are the results of racism. And so we need to be able to tackle that. And one of the ways that we can do that is by having more data on race and ethnicity as it relates to our healthcare experiences. Again, this was outlined in the paper that I have a picture of on the left, which you can find on our website. So really, what do we know about the state of race and ethnicity data? We know as it relates to COVID-19 epidemiological data, specifically from the CDC, that there's been some gaps as it relates to the reporting and collection of race and ethnicity. So we know that as of Friday, with COVID-19 related cases, there's only 52% of those data points that were connected to race and ethnicity. We know that as it relates to COVID-19 related deaths, only 75% of those mortalities were associated with race and ethnicity. And so there's a big gap that we even see now with race and ethnicity as it relates to COVID-19. Within our HHS program, specifically Medicaid and Medicare, we know that there are gaps there as well, despite federal mandates, which we'll get into, adequate reporting of race and ethnicity. So in a recent report, we saw that 20 states identified within Medicaid actually had high concern of unusable race and ethnicity data. And that's because either the data were missing and there was high variation in comparison to data within the US Census. And again, this is concerning because if we don't have proper information as it relates to Medicaid disparities and inequities, then again, we're unable to really tackle these patterns of systemic racism that we see. And secondly, within our Medicare system, we know that there is a history of having challenges with the validity of the racial codes in particular within these analytical enrollment files. And there's also different ways that this information is collected. Self-reported race and ethnicity is the gold standard, but we know that that's not always the case, that we can get that self-reported information. And so there are gaps as it relates to specifically Asian Pacific Islanders, Hispanic, American Indian, and Alaska Native populations as it relates to the validity of those codes related to race and ethnicity. And again, this is important because if we want to talk about how to advance health equity, we need to have a good grasp and take on what are the current health inequities as it relates to race and ethnicity today. So before we kind of really dive into more information within this paper, I kind of wanted to take back into some of my training as it relates to really the conceptualization around race across different disciplines and how we actually know that this is actually a very complex measure that's not just, that actually isn't related to ancestry at all, but it's actually a social measure, right? And so that thread really runs through and how we understand race and why it's actually a very complex measure. We know from sociology that race is actually a social construct. So it's not, again, based upon biology or ancestry, but it's really a social construction of power dynamics. So the power imbalances that we see with me, for example, being a Black woman, would result in racism, which would then result in racial health inequities that we see in our system. So we know that, and because race is layered and it's not simple, I believe that's why we see a lot of the different variations and misclassifications as it relates to race. Secondly, we know again that race exerts its effect through racism. Within this health equity call, there's been more fuel, I would say, into this belief that, you know, it's not the responsibility of the parties who are within the lower power imbalance, right, to fix racial inequities, but it's really the job of everyone leaning in to fix racism, which is actually exerting the effects of racial health inequities. And then lastly, we know that race and context of place matters, which we've learned through public health. So we can know and understand that, similar to Dr. Chandra was saying, you know, it's not just about your race or even how, it's not just about your race, but it's about your place, right? What access to resources do you have? Are there grave health inequities in your neighborhood? Do you have access to local foods? Do you have access to healthcare and things like that, right? And so race and context matters. It's not just who you are, but it's also where you sit in the world, in your neighborhood. And then lastly, one other thing that's not mentioned here is that, you know, there's been a lot of literature to support just even the different ways that, again, we understand race, that it's not necessarily even how you perceive yourself, but it's how the world actually perceives you. So it's socially perceived race. So for example, you know, are you perceived as being white? Are you perceived as being Latino? My brother is mixed race. However, he, in a lot of areas, he's perceived as being Latino. So he wouldn't actually experience some of the negative consequences as being perceived as being Black, even though that's how he would classify himself. And so race is social, it's dynamic. And I think that's another reason why it's been so difficult to really harper down on even how to measure it, because it is a dynamic and not static nature. So again, kind of really diving into our paper as it relates to the collection of data around race and ethnicity and social challenges as it relates to health disparities. This is a 3-part paper series The first one recently released in 2021, really around challenges to national and state data collection as it relates to race and ethnicity, and also correlates of health disparities, so our social determinants of health. And then our second paper will focus on solutions to advancing data as it relates to race and ethnicity and correlates of health disparities. And then the last one, we're really interested in doing the work of actionable policy change to improve disaggregated race in data collection. So that will be the subject of our third paper. But today we're diving into kind of what are the challenges as it relates to the national and state data collection of race and ethnicity, which we'll dive into now. So really, at a high level overview, we found that there was 3 key challenges to meaningful data collection as it relates to health disparities, which I've outlined here. We got this information from doing interviews with individuals at high levels within the healthcare system across different states. And we also use literature to inform this information as well over the last year. The first key challenge that we found is that the types of data as it relates to health disparities are not mandated, not standardized, and also not granular enough to be able to really tackle the racial health disparities that we need. Again, we know that racial health disparities, are at the local level, right? And so we need to be able to have granular community level information and be able to tackle those, and oftentimes that is missing. Secondly, we know that data collection systems are outdated and oftentimes don't allow for interoperability, which is a challenge that the United States has been grappling with for the last couple decades. And then lastly, we know that providers and patients in particular have real concerns about the collection of race and ethnicity in data collection and its importance and in the collection of that. So just diving into the first key challenge, again, the types of data are not standard, not mandated, and not granular. We know that standardization did improve from the Affordable Care Act, which actually reinforced the 1997 OMB race and ethnicity standard categories, which classifies that you need a minimal of 5 racial categories and 1 ethnicity category, being Hispanic or not, in all publicly funded national health surveys. But we know that those standards have not necessarily been met by all reporting entities. We just saw that data as it relates to CDC, as it relates to Medicare, as it relates to Medicaid, and then also at the local level. So despite this law being into effect, we know that we still have some real meaningful gaps, which we'll actually get into as to why that may be later on in the presentation. Secondly, we know that mandates that come from that Affordable Care Act legislation, again, have not necessarily trickled down to all levels, particularly as it pertains to CDC as well. So we saw from a 2018 CDC analysis of 125 CDC-sponsored programs around surveillance and health, that actually only 80% of those systems are actively collecting information as it relates to race and ethnicity. And lastly, there's a question around granularity. There's been major calls, that even the 5 standards as it relates to race and ethnicity are not enough, and that we need to really value the heterogeneity of populations, which gets into background and culture and language, and also, what are those social disparities surrounding populations, right? Like at the local level. And so we need this granular information, again, to be able to really target and understand, hey, if I'm looking at racial inequities in community X, then I need to really understand the context in which these individuals sit, so that I can really make a change that's going to have the greatest amount of impact. And so that granular level information is not there, which feeds into the broader problem. Secondly, again, the second challenge that we found is that our data collection systems are outdated and do not allow for interoperability. I really like this figure from AHRQ, just showing the complex healthcare system that we have and the different places in which healthcare data is collected. So if we're thinking about race and ethnicity, really traveling through this system, we can see how it may get lost kind of along the way from the patient medical record experience all the way up, right? And so if we have different points in which that data is not completely accurate or underreported, that's going to feed into our broader level learnings around racial health inequities and disparities. And so this is an important just way to kind of take a step back and look at the whole system and understand that if our systems are not talking to each other, then we're going to continue to have these issues. And then thirdly, a very real challenge that we see is around providers, right, being apprehensive around the collection of race and ethnicity for a myriad of concerns. In these interviews, we ascertain that, some providers may not believe that racism or disparate outcomes are even a problem in their practice. And so if that is the case, then we're going to continue to have major health inequities if we don't believe that racism is even there from the outset. We can also think about patients, right? And them having very real concerns around the legacy of racism and really the exploitation of health systems. And so we know from historical examples that there is mistrust within certain communities because of historical racism. But I would also say that within the social justice movement today, right, we see racism in present day, which also impacts the way that patients seek care. I love the saying that, health experiences, when you walk into a hospital, right, it's not like you totally disregard all the experiences that you just had on the street corner to get you up to the hospital. And so health experiences are not experienced in a vacuum. We need to understand that the racism that patients face in everyday life have an interaction with the healthcare system. And so the two are very much interrelated. And then lastly, again, patients understandably cite mistrust and concerns that the data may be used for discriminatory practices or adverse health care experiences when surveyed, right? And so you may not want to provide that information. I can say that sometimes I tense up when someone asks me about my race. Is that going to impact my healthcare experience today? And so that's important for us to understand, is that there are very real concerns around mistrust that we need to deal with, not at the patient level, but at the system level, creating systems in which actually empower patients and looking at it from a system level view. And then it's kind of the question of, what does this all mean? And why is it important? And, why does this incomplete information about race and ethnicity really obstruct our ability to address health inequities? And so kind of taking a big picture view, I think it's important for kind of three reasons. One is that the patterns of health inequities around the US, again, we're not able to measure them if we don't have good information as it relates to race and ethnicity. The hope is that over time we'd be able to kind of close those gaps. But we don't know if we're closing the gaps if we don't have the data up front to really be able to tackle it. I'm going to say another one is that if we don't have granular level data, especially within subpopulations, there may be large gaps of health inequities that we don't even see because policy is built upon, in many aspects, data. And so there may be a lot of understudied populations, and we know that, right? And so we need to do a better job of collecting this information so we can then tackle those health inequities. One of the second reasons is that, there may be heterogeneity in the value of care that patients are experiencing. And by not understanding racial ethnicity, racial disparities as it relates to value of care, we may be actually masking opportunities to really close those gaps in those disparities in relation to health outcomes. So even very similar to the presentation Dr. Chandra just gave, if there's differences in the value of care that patients are experiencing across our healthcare system that are systematic as it relates to race, then we need to understand that and unmask that so that then we can begin to close those gaps through real policy change. And then last one is as it relates to systemic racism. Again, race exerts its effects through racism. And so we need to do a better job of understanding, how is systemic racism plaguing our healthcare system? And what are the misaligned incentives, in the impact of access to care and delivery that are perpetuating these negative differences? So better collection of this information will help us be able to tackle systemic racism in our system, which we know is very real today. So that's all I have as far as presentation is concerned. I look forward to your questions.
Dr. McRae, thank you so much. That was excellent. So much of kind of the questions I have you already covered, but I'd like to dig a little deeper on the collection of the data from a patient perspective. You mentioned distrust in the system. Even if we get the infrastructure completely right, even if we're able to mandate granular collection of data, if there's that distrust, there's not going to be good data. And as you mentioned kind of earlier, bad data kind of results in bad policy. Can you talk about ways to overcome this almost intergenerational trauma, this distrust that even you yourself experience when people ask you about race data?
Yeah, ways to overcome it. I think that the most, one of the biggest ways that we need to overcome it, two, if I have two. One is understanding the lens of communities and where they sit in that distrust, right? Because I think that oftentimes we place that distrust on the patient and say, hey, there's distress, and then almost kind of wipe our hands clean and say that there's nothing we can do about it. But if we take the opportunity to actually learn from communities, there may be small changes that we may be able to make to actually improve that trust, right? And so I think it's about folks in the healthcare system taking ownership of that distrust and then meeting patients where they are to tackle that. I think that's very important. And then another thing I think is so important is language. I think that folks in the healthcare system owning the inequities as a real social justice issue. It's not just a disparity, that there's just differences that are just differences. It's like, no, this is related to racism, and we're going to do a better job of it. I think that if organizations, own that language, it will speak to patients and speak to populations and learn from them. So I think we need to do a better job of owning the language and owning the problem so we can help fix it.
Well, that's excellent. As a provider, I feel like I'm learning so much as I go through this. The fact that 52% of COVID cases doesn't have racial data. It's mind-blowing to me as a provider. And I could tell you in medical school, being taught race as a risk factor, almost like it's genetic risk factor as opposed to a socioeconomic or a social construct risk factor. Yeah. So thank you so much for that. Big question. So this is kind of taking a step back from what you're presenting. Obviously, health equity is the forefront of attention with everything happening with COVID, with the racial injustice that we've been seeing over the past year. That's been there forever, but that's really been brought to the forefront. If you could wave a magic wand, what is the one biggest thing that you think we should target as our approach?
Such a good question. I think that social justice movements, which, we shouldn't be mistaken that this is what this is as it relates to health equity, has always been powered by the communities in which are disproportionately impacted by them. And so I think that taking that social justice frame to the forefront of healthcare is what we need to do. So, we really need patients to be partnering, right, and understanding and learning from them. Like, if we're not doing that, then we're not doing the hard work of health equity, which is not just outlining the disparities and then kind of coming in and to communities and telling them what we think we should do. Policies that are empowered by the voices in which they'll be impacting probably won't work and probably will fall flat, right? And so I think it takes some hard work to learn from communities and what's best for them and what works for them. And I think that that's the gap that we need to make as it relates to health equity. And then secondly, I keep going back to this word language, but I think that it's really, really empowered the health equity movement. You know, calling out systemic racism as the factor that causes racial health inequities is critical and key, because if we just say that we have disparities that have existed and have been existing, then we're kind of wiping ourselves clean of the problem. But if we understand that we all have a role to play as it relates to health equity, and that the language that we use, the way that we describe studies, right? Like the way that we write our method section and why is race important is a really critical part of the conversation to make sure that, you know, even the studies that we do will speak back to the populations in which they sit. I'm always kind of, even as a researcher myself, I'm always kind of asking myself, you know, why am I adjusting for race? Why is this important? You know, am I actually doing the necessary work to be able to make these inferences as it relates to populations? You know, would my grandmother be proud of this study, right? Like that's kind of how I kind of judge myself. And I think that we need better data to be able to empower that, but then we also need the language and the training to kind of go behind it to really to speak to the issue, which is what this is. So I think that it's multiple things. And if I could tag one more, I think that it's around training. You know, I think that it's around training. I think it's about diversifying providers. I think it's around diversifying pharmacists. I think it's around the diversification of our healthcare system and who has a seat at the table. Because if we don't diversify that clout, then we'll continue to miss things because we won't see it from our lens. So those are probably the three biggest things that I think we need to do. Learn from communities, use better language, and then diversify our healthcare system.
That's amazing. Thank you so much for that. I could ask you a gazillion questions about everything that you just said. I think getting down to that community level, building that trust, obviously, like you mentioned, will help us collect data. But that using that language, I think is so powerful. As a provider, you get really anxious about actually saying the word racism because it labels things that you do and not in a good way sometimes. So thank you for all those comments. I'll pause there knowing the time, and I'll hand it off to Serena here.
Hello, so I'm Serena Gulga. I am the Director of Operations here at PTech. And so I'm thanking Dr. Chandra and also Dr. McRae for your excellent presentations on health equity. And as I'm listening to these talks and reflecting on some of the experiences I've had in the past, so I have trained both as a pharmacologist and a social worker, and I have sort of stories that are related to both of these talks. So my research as a pharmacology student was actually focused on early childhood adversity and its effects on adult health. And at the time, I wanted to collect race data on my participants. However, my advisor did not think it was important. And obviously, we know that racial discrimination is a significant contributor to adversity and differences in health, both in childhood and adulthood. And so it was really frustrating because I'm sitting here, I know that this is really important, but I'm working with someone who actually is a physician, a psychiatrist, in fact, who did not think that this was a significant contributor to health and did not think that this was important for me even to adjust for it in my data. So I had outcomes that I felt were not complete. I did not think that what I had produced was effective enough. You know, it felt uncomfortable. And so when I was in social work school, however, I actually participated in a community-based participatory research project. And you've noted that working with communities sometimes is very difficult. And I actually experienced that because the work that I did was actually driven by the patients. So the questions that they had were driven by the patients. Were those the questions that we had as researchers? No, but we had to recognize that ultimately the patients are the ones who are being affected by the data. And so why not have the patients determine the data that's important to affect changes in the healthcare system and downstream, ultimately, the care that they receive. So I really think that what we've heard is a call to action. As a trained as a social worker, you really think, okay, I have this information, but what do I do with it? And I think that's really where we are right now. And perhaps even from, with Dr. McRae's presentation, we don't even have all the data that we need to say, what do I do with it? So we really need to think broadly about when we're saying we're going to use data and health equity, and even step back and say, why? Why are we connecting the data that we have to affect change? We're sort of in our infancy, if you will, in terms of how we can use data to affect change in the healthcare system at multiple levels. And so ultimately, we're looking at data in service of action. So we want to know how we can move forward. What do we talk about social determinants of health, we talk about differences in geographical distribution. Okay, that's great. What do we do with it? And so I think really I think what you should take from this, hopefully, is that we don't have enough. And without having enough data, we're not going to do anything about it. And we think that we are. We may think that we're implementing change, but we're really not if we don't have, as Dr. McRae showed, we don't have what we need to really do that. So I hope that everyone leaves here that's thinking about that data in service of action and taking action to get the right data. So I would like to thank again everyone who's attended, and Dr. McRae and Dr. Chandra for joining us today. And we will have this recorded. It will be uploaded on YouTube soon. So if there's anything you missed from these excellent presentations, be sure to look for that. It will be posted to our website, and we will also send out email links to that. So with that, we'd like to close and thank you everyone for coming, and